This is Joanne Lamoureux, and I'll be narrating the PowerPoint presentation regarding pharmacology and local anesthesia. What are local anesthetics? Well, as you read, these are drugs that block nerve impulses in a reversible manner. Our main objective is to block the sensation of pain, and to do so in a very restricted or localized area in the body. I think it's important to keep in mind that we can block any type of nerve fiber with these drugs, but our objective is to block sensory nerves. Fortunately for us, they're the most easily blocked of all of the nerves that we could block. Most importantly, we're blocking sensory nerve endings and nerve trunks. I think it's important to remember that sensory nerves send impulses from the periphery of the body in a direction toward the central nervous system. So when we put a local anesthetic in place, basically we're setting up a roadblock somewhere between the area that we may be causing discomforts in our patients and the brain. So any impulses don't get by the little roadblock that we set up. One of the differences between local anesthetics and other drugs that might block the sensation of pain is that they don't produce a loss of consciousness. Something else that's important to remember about local anesthetics is that other drugs, in order to have an effect in the body, have to get into the bloodstream in order to reach their site of action and have their effect. Local anesthetics become actually ineffective when they enter the bloodstream, so our objective is to keep them out of the circulatory system for as long as possible. This does two things. It increases the duration in our working time and decreases the potential toxicity that these drugs have when they enter the bloodstream. I think it's important to understand that when a local anesthetic blocks nerve function, it does so in a particular order. And you'll notice here that even though we've blocked the sensation of pain, our patients might still feel touch, pressure, or vibration. It's important to know about this because sometimes patients will tell you they're not numb enough, and we have to differentiate for ourselves and our patients whether or not what they're feeling is true discomfort versus still some kind of sensation. You read about local anesthetics having desirable properties, and as you know, there are not any local anesthetics that contain all of the desirable properties, but most of them available to us are relatively non-irritating to the tissues that we inject them into and do have a completely reversible effect. It's important to note that all local anesthetics, with the exception of cocaine, actually make blood vessels dilate or get bigger. And when blood vessels in the area get bigger, that carries our anesthetic away, giving us a shorter working time. And that's why it's important that the local anesthetic that's produced be compatible with another drug called a vasoconstrictor. The vasoconstrictor is put in there to make these to be actually have the opposite effect of the vasodilation, and therefore increase the duration that the anesthetic stays local and doesn't enter the bloodstream. This decreases its systemic toxicity. We also want drugs that have a relatively short onset. That means we get the anesthesia relatively soon after injecting the drug so that our working time isn't delayed. But we want that drug to have a sufficient duration. We also want the patient to recover soon after we've stopped needing the local anesthetic. We don't want them walking around all day feeling numb. And lastly, local anesthetics should be effective by various delivery systems. As you may recall, local anesthetics are not effective when we take them orally because they're destroyed by the enzymes in the liver, but they are effective for us in two ways in dentistry, that is, by injection or by applying them topically. Some anesthetics are effective by both of those delivery systems. Some can be used only topically, and some can be used only by injection. The principle of diffusion is an extremely important one for you to understand how local anesthetics work, and why when sometimes you inject a patient, the local anesthetic might not work. Basically, diffusion says that when you put molecules together in a solution, they're going to just sort of have random movement. And this movement, when it takes place on one side of a barrier, is going to cause the molecules to pass across the barrier, if they're capable of doing so, to equal out their concentration. This is what's called flowing with the concentration gradient. With local anesthetics, it's important to remember that the greater the initial concentration of the local anesthetic, the faster it will diffuse into the area where we need it to go to work, and the faster the onset of action. Keep this in mind when you first begin injecting patients. It's my experience that new clinicians are a little bit reluctant to inject enough local anesthetic. Better that you err on the side of caution, but if you are hitting your target site and it's taking too long for your patient to get numb, or they don't get numb enough, take a look at how much anesthetic you're actually putting into the tissues. Perhaps you have not created enough to cause rapid diffusion. Another principle that's important to understand with how local anesthetics work is that of polarity. Basically, polarity says that opposite charges will attract to one another, and like charges will repel. So what do we mean by charges? If a molecule has gained an electron or has lost an electron, it has become ionized. When it is in its normal state and has neither gained nor lost electrons, it's referred to as being non-ionized or unionized. In our nerve impulse transmission, there are a greater number of positively charged ions outside the nerve. These are primarily sodium. And a greater number of negatively charged ions inside the cell, and this is primarily negatively charged protein molecules in the exoplasm of the nerve in the exoplasm of the nerve. What keeps this positive charge on the outside from being able to attach to the negative charge on the inside is the cell membrane. But the positive wants to be drawn to the negative, so there's basically a potential attraction that exists here. It's important to keep in mind that a resting nerve is in this state of polarization. All that means is that you have a whole lot of positive ions on the outside that want to get at the negative ions on the inside. Let's take a closer look at the nerve itself. What you see in this diagram, and I hope you can see my cursor moving around, extracellular fluid. This is fluid outside of this nerve membrane. These little pinkish colored dots represent the nerve membrane itself. It is a double layer of lipid protein. So these positive charges you see out here are sodium molecules. Inside the nerve are negatively charged proteins. The attraction of the positively charged sodium to the negatively charged protein can be measured as an electrical difference, and that difference is called millivolts. The electrical charge of a resting nerve is negative 70 millivolts. This is indicative of the fact that the inner surface of the nerve, or the exoplasm of the nerve, is negatively charged. As I mentioned before, the positive ions want to come together with the negative ions. They're separated by the nerve membrane, but when they do come together, that creates an electrical current. This results when sodium is allowed to flow into the exoplasm. What's important to understand here is that enough sodium has to flow in order for that negative 70 millivolts to begin to reach what is called the firing threshold of the nerve, and that's when it reaches around negative 55 millivolts. As the more positively charged ions come in, the negative millivoltage goes up because now you have more positively charged ions on the inside. So why is this important? Well, when nerves send an impulse, they go through two stages of depolarization. Remember, they're at resting stage, they are polarized. When a nerve stimulates them, they become depolarized because the positive is able to get at the negative. The first stage of depolarization is called slow depolarization. That's as when a nerve is stimulated, the channels that allow the sodium to flow inward open a little bit and a few sodium molecules come in. As they start to trickle inside the nerve and the threshold goes up, you have slow depolarization. When that threshold reaches negative 55, then you are looking at what is called the wave of rapid depolarization. This is kind of like the same effect you get if you have dominoes set up. You know, I'm sure you've seen people who do these elaborate domino schematics. Think of the stimulus as the finger that pushes over the first domino. And as the dominoes begin to fall at first, it's at a rather slow rate. That is the rate of slow depolarization. But once more and more dominoes fall, you don't need any further finger to push over the rest of the dominoes. The dominoes push over one another, and then they all fall down. So that's the difference between slow depolarization and rapid depolarization. The stimulus causes the initial slow depolarization, but the influx of the sodium ions is what sets up the electrical current that creates the rest of the depolarization. So all that means is the nerve doesn't need any further impulse in order for it to fire its action potential. How this all relates to local anesthetics is that the local anesthetics raise the threshold, raise the firing threshold, and that means more sodium ions would have to enter the nerve in order for rapid depolarization to occur. So what you want to remember is if a nerve cannot reach its firing threshold, it cannot depolarize. Sodium must enter the nerve during depolarization, and once it has entered in sufficient quantities, potassium has to exit the nerve, and both of these molecules must use a channel to cross the nerve membrane. These channels are called voltage-gated channels. That means that they will open in response to a certain electrical charge. There are activation gates which open during depolarization and inactivation gates which close to stop further entry of the sodium or further exit of the potassium. The reason that sodium can't just leak through these channels is that sodium is always attached to a molecule of water, so the resulting chemical is too large to use the channels. The channels have to get wider in order for sodium to come in. What keeps those channels closed up in a resting nerve is a molecule of calcium. Calcium is bound to the receptors inside the channel, and when something stimulates the nerve, the first thing that happens is the calcium is released from its receptor sites, and that causes these channels or gates to become wide enough for the sodium to rush inside the nerve. This is a schematic of what it looks like. In the first diagram here, the channels are closed. This is the activation gate, which closes off the top, and you'll notice a resting membrane potential of negative 70 millivolts. As the gate opens up, and again this gate opens up because there's a calcium molecule in here that keeps the gate closed. The nerve gets stimulated by something, the calcium gets released. When calcium gets released, the gate widens and allows sodium to come in. When enough sodium has come into the nerve senses that there's more positive charge on the inside and more negative on the outside, so it closes the gate to keep more sodium from entering. Then other gates open and allow the negatively charged potassium to leave the nerve, and then the nerve repolarizes and goes back to its resting state. Another key thing to understand about nerve impulse transmission is that we have both myelinated and unmyelinated nerves. Unmyelinated nerves are very small axons, and they do not have a protective sheath around them, and they conduct impulses at a very slow rate. Most of the nerves that we're trying to block with a local anesthetic are myelinated nerves. Myelinated nerves are covered or wrapped in a layer of lipoprotein called a myelin sheath. But periodically, at regular intervals, there are openings in this myelin sheath, and it's at these openings is the only point at which sodium can enter its channels. Therefore, when this type of nerve is stimulated, sodium enters here, and the nerve impulse travels at a faster transmission because it jumps from node to node. By the way, these are called the nodes of Ranvier. This jumping from node to node is called saltatory conduction. So it's important for you to understand two things about myelinated nerves. One, they conduct impulses at a faster rate of speed. And two, these impulses can skip over one or two nodes when they become blocked. So when we administer local anesthetic, we have to put in enough anesthetic so that the anesthetic will diffuse or spread out the distance of at least 2 to 3 nodes, which is equal to about 8 to 10 millimeters. And again, this goes back to what I said originally. We have to make sure that we put enough local anesthetic in so that we get enough diffusion. It's important to remember with diffusion that when you put molecules into an area, they're going to diffuse toward the nerve, but they also have the capability of diffusing away from the nerve, so you have to make sure you have enough anesthetic molecules close enough to the nerve in order to get adequate anesthesia. Let's just do a little recap here about how a nerve conducts an impulse. Something stimulates the nerve. That stimulus causes calcium to become unbound from its receptors in the sodium channel. This sets up the wave of slow depolarization, which opens up those gates I showed you. When enough sodium comes in, the firing threshold is released and a wave of rapid depolarization takes place. Sodium goes in, the gates close, then potassium passes out and the potassium gates close, and the nerve repolarizes and establishes a re-equilibrium between the amount of potassium and sodium on the inside and outside of the nerve. This little video clip is just a demonstration of how the gates open, sodium comes in, and as that's happening, you will notice the millivoltage rises. When it reaches its critical peak, the nerve senses this and opens the potassium gates to equilibrate again, and then it comes back down to a negative resting millivoltage. These next two slides are just a still representation of everything I've said. During the resting phase, the channels are closed, you have a stimulation, the channels open. The cell becomes depolarized and the sodium channels close. Potassium exits down its concentration gradient through its own channels, and the fiber becomes repolarized. There's a pump that restores the balance between sodium and potassium ions. The nerve returns to its resting polarity of -70 millivolts. This puts the whole piece together. Action potential is stimulated when you reach a certain millivoltage. That means the nerve will fire all along the length of its axon. So how do local anesthetics work? I'm going to skip to this next slide because it has a little diagram to help me do my explanation. As I mentioned, when a nerve is resting, the channels that sodium has to use are too closed. What keeps them closed are calcium molecules that are bound up to very specific receptors inside this channel. When something stimulates the nerve, the first thing that happens is the calcium becomes unbound. When we administer local anesthetics, they cross this nerve membrane, get inside the axoplasm of the nerve, and go up inside these sodium channels, displace the calcium. They actually can literally remove the calcium from their binding site, take the place of the calcium, but instead of being displaced when something stimulates the nerve, the local anesthetic molecule stays attached. That means the channels are too closed or too plugged up for enough sodium to come in, and the nerve can't reach its firing threshold. Therefore, there's a decrease in this membrane's permeability to sodium. If sodium can't get in, the nerve cannot conduct an impulse. So simply put, local anesthetics block what is called the wave of depolarization. Here it is in probably more understandable words. Local anesthetics block the conduction of nerve impulses. Well, how do they do that? They plug up the channels that are normally used by sodium to enter the nerve. Well, so what? If sodium can't come in, the nerve cannot depolarize. If the nerve can't depolarize, the patient is not going to know that we're making them uncomfortable. So local anesthetics block the wave of depolarization by making the nerve membrane less permeable to sodium. It's important to keep in mind that local anesthetics have the potential to block nerve impulse transmission in any nerve membrane. And two of our body's systems, the central nervous system and the cardiovascular system, or nerves within those two systems, are particularly susceptible to the effects of local anesthetics. That's why it's important to remember that we do not want to get too much local anesthetic into the bloodstream at any given time, because once it enters the bloodstream, it can be carried to those nerves of the cardiovascular or the central nervous system where it can have an effect. At low doses, local anesthetics can be used therapeutically. If you remember from your reading, they can be used therapeutically in low doses for conditions of cardiac arrhythmias and cardiac arrest. They also have been used in very low doses as anticonvulsants or to stop convulsions. However, in higher than normal or toxic doses, Local anesthetics can both precipitate a cardiac arrhythmia, precipitate cardiac arrest, or precipitate a convulsion. The important point to remember here is that if we use a normal dental dose, we use a vasoconstrictor, we aspirate, and we don't overdose the patient on a local anesthetic, none of these things are going to happen, or are not likely to happen. It's important to know something about the chemistry of local anesthetics. First of all, local anesthetics in their natural state are weak bases. And in their natural state, they are also very unstable and poorly soluble. That means when you expose them to air, they don't work very well. Because they're poorly soluble, we have trouble injecting them. Therefore, they have to be mixed with other chemicals in order to get them into an injectable form. What local anesthetics are primarily mixed with is hydrochloric acid. When you mix the weak anesthetic base with the hydrochloric acid, you form an anesthetic salt. The resulting anesthetic salt is very stable and is also water-soluble. That means you can mix it up in solution and get it into a form in which you can inject it. There's two other things that you need to understand that result from the chemistry of local anesthetics. And that is this. When the anesthetic is in its free base form, that means it's not been mixed with anything. It is called the free base molecule, or Rn. You will notice there's no charge here. But when you mix that free base with other potential molecules, there can be the potential for that free base to couple itself with a hydrogen ion. Now it is a positively charged molecule. Here it has no charge. It has not gained or lost an electron, and therefore is called a non-ionized or unionized free base. When you mix it with the hydrochloric acid, because this is an acid, that means there are a higher number of hydrogen ions available to couple with that free base, and this puts a positive charge to the free base. This RNH becomes known as the cation. And in every solution of local anesthesia or local anesthetic, there are a certain ratio of free base molecules to cation molecules, and as you'll see in just a few minutes, the amount of free base to cation molecules becomes important to understanding how well a local anesthetic can work. It's also important to note that the pH of a local anesthetic without a vasoconstrictor is 5.5, but by adding a vasoconstrictor, we make the pH of the local anesthetic much more acidic. Eventually, you'll come to understand that having a lower pH delays the onset. So when you use a local anesthetic that has a vasoconstrictor, your patient will still get numb and will stay numb for a longer period of time, but you should expect that it will take them longer to get numb when you're using an anesthetic with a vasoconstrictor. It has to do with this pH. As I mentioned, when we have drugs in solution, there's going to be an equilibrium, or a ratio that exists between how many free base molecules we have and how many positively charged cation molecules that we have. This number is important because it helps determine how fast the drug works, how long it works, and the overall effectiveness of it. How many of each of these different types of molecules we have depends on three different things. What's the pH of the anesthetic solution to begin with? What is the pH of the tissues into which we're putting the local anesthetic? And something called the pKa of the drug itself. As I mentioned, in the solution, the local anesthetic exists simultaneously in a certain ratio of free base molecules to cation molecules. And the pKa of the drug determines how many of these molecules will be free base and how many will be cation. This is determined by something called the dissociation constant. Hang with me because this stuff is a little bit difficult to understand and even harder to explain. But a dissociation constant is a measure of each molecule's affinity or attraction toward hydrogen ions. And the principle of dissociation constant, or pKa, says that a drug's pKa is the pH at which the drug will dissociate or separate equally into ionized and unionized forms. In order to understand this, it's important to remember that when we have a low pH or an acid environment, pH means percentage of hydrogen ions. So when you are at an acidic pH, the low numbers between 1 and 6, you have a high percentage of hydrogen ions. If you put a chemical that is a base into a acidic pH, there are more hydrogen ions to couple with that base, and therefore more of your molecules will become charged up and be in the cation form. If you keep a substance that's a base in an environment that's also a base, there are less hydrogen ions for it to couple up with, so it retains more of its free base form. So what is the importance of all of this? The importance here is that the free base, the uncharged local anesthetic molecule, is the molecule that actually penetrates the nerve fiber. But once that free base molecule gets inside the nerve fiber, the molecules that get in will then again dissociate from one another into certain amounts of charged and uncharged forms. It's the charged form of the local anesthetic molecule, the one that picks up the hydrogen ion, that actually ends up blocking the sodium channel. So what you need to understand is that we need molecules in their free base form to get inside the nerve, but then we need those free base molecules to dissociate, pick up some hydrogen, develop into a cation form, and block up the sodium channels. This is a drawing that basically says the words, shows the words that I just spoke. If you look here, when we give an injection, because of the pKa of the drug, and the pH of the tissues and the pH of the drug, we're going to get a certain amount of molecules which are free base and a certain amount which are ionized. As I mentioned, only the free base molecules are going to be able to penetrate that nerve fiber and get inside the axoplasm of the nerve. But once they get into the axoplasm of the nerve, the free base molecules, because of the pH of the axoplasm and the pH of the anesthetic itself, there will be a further dissociation, a separation. Some of these molecules will pick up a hydrogen molecule from inside this nerve and become positively charged. It is these positively charged or cation local anesthetic molecules that are able to block up the sodium channels from inside the nerve. Here are some examples of dissociation constants. If you have a drug that has a pKa of 7.9 and you put it in an environment where the pH is also 7.9, that means the pH equals the pKa of the drug, and that's the point at which you will get 50% charged and 50% uncharged molecules. If you take that same drug with a slightly basic pKa and you put it in a pH where the pH is slightly less basic, you'll notice that what you develop, because in this pH you have more hydrogen molecules, you get less free base and more positively charged cations. Now on the surface this might sound like a bad deal. You say, well, wait a minute, instead of having 50% free base, now I only have 25% free base. But what you need to remember is that of these 25% free base molecules, once they get inside the nerve, a full 75% of them are then going to become positively charged cations, which can block up that nerve. The pKa of most of the injectable anesthetics that we use, you will notice, is on the basic side, from 7.7 to 8.1. You also need to know that the pH normally in our tissues is around 7.4. Therefore, the pH of our normal tissues where we're putting the drug is usually less than the pKa of the drugs that we're putting into those areas. So when the pKa is higher than the pH, we end up with more positively charged ions. This slows our onset of action. It doesn't mean that the drug doesn't work. It just means it takes longer to do so. Why is this important? Well, this whole thing is important to understand because otherwise it's impossible to understand why local anesthetics don't work when there's inflammation or infection in an area, which we're often dealing with. First of all, when we have infection or inflammation, there's increased vascularity. That means the blood supply to the area is increased. The blood vessels in the area also dilate, and there's more fluid in the area. So the local anesthetic is going to be carried away from where we put it at a much faster rate because it gets diluted by the localized edema, and it gets sucked up into the bloodstream by the dilated blood vessels. The third thing that happens is in areas of infection or inflammation, the tissue becomes much more acidic. I mentioned before that normally tissue pH is 7.4, but when there's infection or inflammation present, this pH drops down to 5.5. So now you're putting a drug which has a pK of 7.9 into an acidic pH. What you end up with is too few free base molecules to enter the nerve. The example down at the bottom shows you if you took a pKa of, if you had a drug with a pKa of 7.9, put it in this pH of 6, you only end up with 1% of free base molecules. That means if you had 200 molecules, only one of those molecules would enter the nerve. That leaves you not enough anesthetic to actually produce local anesthesia. Your textbook gives you some information about the organization of peripheral nerves. I think what's important to focus in on here is not so much that you remember what every single one of these layers is all about, but that you do remember what we have are many axons that are all packed up together, and these axons are protected by several different layers. Some of these layers make it more difficult for the local anesthetic to penetrate than others. The induction phase of local anesthesia is the time period it takes for the local anesthetic molecules to move from where we put them toward the nerve. But it's important to remember that those molecules can move toward the nerve but move in any other possible direction. This process of molecular movement is what we call diffusion. And during the process of diffusion, there's basically an unhindered movement of the molecules through a fluid medium, and all of this is under the influence of the concentration gradient, meaning you have a whole lot of molecules in one place, they're in fluid, they're going to flow to an area where there's not a whole lot of molecules in some other place. The other thing to focus on is that the greater the initial concentration of these anesthetic molecules, the faster they're going to diffuse and the more rapid the onset of our local anesthetic. Two other things to key in on here are what I call the mantle bundles and the core bundles. The mantle bundles are the nerve fibers that are closer to the surface of these packed up neurons. And because they're closer to the surface, they're the first ones that get reached by the local anesthetic. The other thing to know about mantle bundles is that they tend to send messages from the more proximal structures, and are also, because they're closer to the outside of the bundle, they are exposed initially to higher concentrations of the local anesthetic. So what do I mean by they serve more proximal surfaces? Well, let's look at the inferior alveolar nerve. Where that main nerve trunk enters is the mandibular foramen, and that's our site of deposition for an inferior alveolar nerve block. The mantle bundles inside that trunk send messages from the molars. The core bundles are the bundles that are further inside, and therefore they receive diffusion from the anesthetic at a much slower rate and are the last pieces of these bundles that get anesthetized. The core bundles, therefore, are exposed to a lower concentration of the anesthetic, and it's important for you to recognize that they serve the more distal structures. So when you block the inferior alveolar nerve, the mantle bundles get blocked first, and the patient loses sensation in their molars, and the anteriors, or specifically the incisors, get blocked last. So when you're checking to see if your patient is adequately anesthetized, don't check soft tissues, check the mandibular incisors first. That means that the anesthetic has worked its way all the way through to the core bundle. The other thing that you should recognize is that the recovery from local anesthesia takes place in a reverse order. That is, the mantle bundles, or the structures served by the mantle bundles, become unanesthetized before the structures served by the core bundles. So when a patient is starting to feel sensation from recovery from an inferior alveolar block, they may feel things in their molars but still be anesthetized in their incisors. It's also important to remember that in order to get complete blockade of a nerve, we have to make sure that we inject an adequate volume and what we inject is at an adequate concentration, because some of the drug is going to be absorbed by non-neural tissue. That means it's going to get carried away. Some of it's going to enter the bloodstream, and if you were using an ester-based anesthetic, some of it would be broken down almost immediately by esters that are in the blood serving that area. Induction time refers to how long it takes to go from the time we put the anesthetic in, that's our deposition, to when we achieve complete blockade, and there are a number of factors that can influence that induction time. Some of the factors that are under our operator control are what's the concentration of the drug that we're using? Did we use an adequate volume? Did we hit our deposition site? And what's the pH of the local anesthetic we've chosen to use? Some factors that are not under our control is the diffusion constant of the drug itself and any other anatomical infusion barriers that are in the area where we are injecting. There are some other principles regarding the chemistry of local anesthesia that are important for us to know about. Local anesthetics are chemically composed of a lipophilic end, a hydrophilic end, and these two ends are connected in the middle with something called an intermediate chain. The intermediate chain is either an amide linkage or an ester linkage, and it's important for us to recognize what the difference is. But first of all, the lipophilic end allows the anesthetic to diffuse through the nerve membrane. Remember, the nerve membrane is lipid in structure, so you have to have something that will dissolve in it in order for it to pass from outside the nerve to inside the nerve. The hydrophilic end of the anesthetic is necessary because it helps get the local anesthetic through the interstitial fluids of our body to our nerve, because those interstitial fluids happen to be water. So you need a drug that has both water solubility and lipid solubility. What connects those two ends of it, again, is the intermediate chain. So local anesthetics are chemically divided into two broad categories. They're called esters and amides. What you need to know about esters, even though we do not use them as injectable anesthetics today, is that they were used for quite some time. They were the first injectable local anesthetic to be developed. And they have basically a very short duration, some of them more moderate, but the reason that they have this short duration is they cause more vasodilation than the amide local anesthetics. The other reason they have a shorter duration is that they are metabolized in the blood by an enzyme called pseudocholinesterase. So it's the presence of this pseudocholinesterase in the blood that increases the rate of metabolism, thereby decreasing the duration of time that the drug has an effect. The other thing that's important to recognize is when these esters are metabolized or broken down by this pseudocholinesterase, one of their major metabolic byproducts is something called para-aminobenzoic acid, or PABA for short. And there are a fair number of people who are allergic to PABA. You may recall that PABA used to be the active ingredient in many sunscreens, and they took it out of those sunscreens because a lot of people are allergic to it. The other thing that's important to recognize is today you're not likely to encounter a whole lot of people who were exposed to ester anesthetics. So when patients report that they're allergic to a local anesthetic, you have to question them carefully, because if they're under the age of 50, they certainly were not exposed to an ester anesthetic. We didn't use them by injection much after the late 1950s when amides came into being. A third problem with ester-based local anesthetics is that 1 out of every 2,800 people has an atypical form of this enzyme. It's called atypical pseudocholinesterase. And when that atypical form is present, it doesn't break down the ester anesthetic nearly as rapidly. So it delays the metabolism and therefore increases the potential for this to be toxic. It's difficult for you to know whether or not somebody might have atypical cholinesterase, and it's not particularly overwhelmingly important because you won't be injecting ester-based local anesthetics. But you should know that in the presence of this atypical pseudocholinesterase, it's considered to be a relative contraindication. Amide local anesthetics are what we use in dentistry today. They have a much longer duration because they cause less vasodilation than the esters, and they also are more potent. They have a very low rate of allergic response. It's considered to be rare, and there are some pieces of literature that suggest that nobody really is allergic to an amide, that most of the allergic reactions have occurred to some other agent that's in the local anesthetic. You need to know that amides are metabolized in the liver. So anytime you're administering them, that means that they metabolism of a drug means that the drug has to be changed by the body in some way in order to be excreted. If the drug does not get changed at the rate you expect and you keep administering the drug, or you administer a very high dose, it takes a long time to metabolize it or change it, the drug stays in the bloodstream and can then be toxic. The people that this is most important for is anyone who has a condition that has decreased the blood flow to the liver, or when they have reduced liver function itself. This would be someone who has congestive heart failure, hypertension in the arteries serving the liver, cirrhosis, history of alcohol abuse or other substance abuses. It's important to remember when the liver does not function normally or at its normal capacity, there is an increased potential toxicity when you administer a local anesthetic that's an amide base, and it's considered to be a relative contraindication. That means that you should use it in the lowest dosage possible. Allergic responses to local anesthetics. As I mentioned earlier, most people are allergic to esters, and if they're allergic to one ester, they automatically have a cross-allergenicity to any other ester-based anesthetic. The allergenicity to amides is very rare, and there is no documented cross-allergenicity. Should you encounter a patient where you can't determine if they're truly allergic to an ester or an amide, and you need to administer local anesthetic, it would be helpful to know that injectable diphenhydramine, which is the drug you probably know as Benadryl, in a 1% concentration that has been combined with a vasoconstrictor of epinephrine, is enough to provide adequate local anesthesia. Although we don't use it a great deal in dentistry, it has been used successfully in patients who have documented amide allergies. You also should be familiar with the fact that there is a chemical called methylparaben, which was a preservative that used to be used in local anesthetics, injectable local anesthetics. They've taken it out as the preservative for the injectables, but there are some topical local anesthetics that still use this methylparaben as a preservative, and there are some people who are allergic to that preservative. There's also a chemical called sodium bisulfate, which is basically an antioxidant. That means it delays the breakdown of other chemicals. Sodium bisulfate and other antioxidants are found whenever a local anesthetic contains a vasoconstrictor. The people that we have to be most concerned about are people who have allergies, in most particular anyone who has allergic asthma to the point where they are dependent on steroids to help control that allergic asthma. That's why you see the words steroid-dependent allergic asthmatics. Those are the people who are most likely to react to the sodium bisulfate in our local anesthetic. Sodium bisulfate was an antioxidant or a preservative that was used at salad bars probably about 10 years ago, and there were some reported deaths from asthmatic reactions to people who ate at those salad bars. So it's certainly something to keep in mind. What are some of the factors that affect the depth and duration of our local anesthetic? Well, first of all, you might want to recognize that when any drug is given, there is a range of response to that drug, even at its normal dosage. There are people who will respond in a normal expected manner. There will people who will under-respond and people who will over-respond. It's the same as there are many people that one beer does nothing for them, they have to have 6. And other people, one beer sends them over the edge. It's the same thing with any other drug. So we have to take that into account. Another factor is how accurate are we? How close to our injection site did we get? What is the status of the tissues where we put the anesthetic? Remember, if we have infection or inflammation, then we're going to get that anesthetic carried away more rapidly and we're going to get less freebase formed. Keep in mind that everybody has anatomical variations, and although you might be familiar with the site of deposition, it's not always accurate, and you're, the blind leading the blind here. You're using anatomical landmarks, but you're not exactly sure where the nerve is. So sometimes we don't get anesthesia because the person's anatomy is so variable from what you would normally expect. Another thing that affects the depth and duration of the anesthetic action is the type of injection we give. The larger the nerve trunk we anesthetize, the wider our zone of anesthesia. And lastly, the chemical properties of the drug that we're using.